the board and cares, assisted living facilities, standalone memory care units, or combinations thereof. So those range in size from more than 100 beds.
We lost
And
your
they
audio.
unfortunately,
We lost your audio for a minute.
Are you hearing me okay now?
Yes.
All right. Let me know if I need to go to the phone. This has worked okay in the past, so anyway. But the RCFEs in general have limited infection control resources and training, and many of them have never really tested for infectious diseases before. And then we have our public health communicable disease division, and there's just one of us, basically, and our team, I'm fortunate now to have a team of nurses who've been pulled from other programs to help out, but basically, our communicable disease control division has to track all cases of COVID in the county. We have to respond to outbreaks in facilities, correctional institutions, businesses, et cetera. So I'm just telling you this because to let you know that we can't possibly do everything for everybody. If you have cases in your facility that we can come running out and test everybody right away, unfortunately, we can't do that. In the ideal world, if I could snap my fingers and things could be done, I would do that. But it requires people, it requires resources. They're not always available. So I'm going to start off talking a little bit about SNFs. I know most of you probably aren't with SNFs, but just to kind of, again, give you a picture of what's been going on. For the first 5 weeks of the pandemic, we were pretty lucky. We only had occasional cases in staff at SNFs, and we did have occasional cases in assisted living, but single cases. Then April 14th, that all changed, and we had two rather large SNFs with outbreaks. Our response at that time was to do a site visit. We tested all the residents at the facility through our public health lab. We advised them on how to set up a COVID unit and quarantine units, and then did repeated weekly rounds of testing. Most of those performed at the public health lab at each facility to detect and isolate new cases. And that very quickly got to testing numbers so large that our public health public health capacity was overwhelmed. Now, one thing we do in the SNFs, and the reason why I'm talking about this is that in some of your facilities, if you have COVID, you may need to do this as well. So cohorting, you may have heard of cohorting or maybe not. This is basically grouping patients with the same disease. So if people have the same disease, they can stay in the same room together, the same area together, and not worry about transmitting the disease to each other, but keeping other people that don't have that disease away so they don't get exposed to it. So in SNFs, we recommend 3 areas when they have a COVID outbreak. They should have what we call a red unit or a COVID unit. That's for acute COVID patients. And in that case, many of the school district facilities have shared rooms, so you can put as many patients as safe to put in a room together. But everything in that unit should be separate from the main facility. It should have a separate entrance and exit for the staff. There should be a separate staff break room, bathroom, nursing station, and dedicated staff. Dedicated staff not mean that your staff are not dedicated. Everyone's dedicated to their job, hopefully. But this means that those staff stay only in that unit during that day or that shift. They don't go from the red unit to other areas of the facility and thus bring, potential contamination to other areas of the facility. Then we recommend having a yellow unit. A yellow unit can accommodate 2 types of patients. That might be the close contacts of COVID patients. So if someone who developed COVID had a roommate who initially tested negative, we know there's a high risk that that person will develop the disease. So we'd like to put that person in a single room if possible, and if not, 2 per room with their beds as far apart as possible, privacy curtain closed, and the patient's masked, and the doors closed so they're not wandering out in the hallway, potentially exposing other people if they develop COVID. And then we have what are called persons under investigations, or PUI. This may be a new term to some of you. The SNFs are pretty familiar with it, but that's basically a person who has symptoms of COVID and is awaiting the test results. So in that case, again, they're in a single room. PUI should not share rooms with others, and their doors should be closed. Then we have a green unit. So that's the area green is clean for the COVID negative, non-exposed patients. So some facilities have decided to transfer all their COVID patients out. They didn't want to try to have a red unit, and in that case, you could just have a yellow and green unit. So this is kind of what's been happening in SNFs here in Orange County. So you see we had our first 2 back in that second week of April. Then the next week we had another 2, and that was a lot of work. Just the first 2 were a lot of work. So then we got another 2, that was more work. Then we got 5, the next 2 weeks, 5 each. And each one of these outbreaks, you have to understand, goes on for weeks and weeks. So it's not like we're saying, okay, you're done, see you later. We had to continue following these. So as time went on and we continued getting more and more, it really became an overwhelming amount of work. So this is the cumulative graph here, where as of week before last, there were 32 outbreaks in skilled nursing facilities, and only 5 of those had resolved. But unfortunately, one of them had experienced a second outbreak. So as of last week, we were dealing with about 27 concurrent outbreaks in various phases, as well as additional facilities which we're investigating for an outbreak. If they have a single case, we don't call it an outbreak, but we ask them to test and to find out if there are any more. So this is the really sad thing. This is the SNF outbreak outcomes to date. So this is as of the day before yesterday. So of those 27 or 30, I think there may be 1 or 2 facilities that are not on here. This is when they started and when they stopped, if they've been closed, how many residents were in that facility at the time the outbreak started, the total number of residents who developed COVID infection, the numbers who died of COVID infection, then the attack rate. So attack rate is of the total residents, how many of them developed it, so the percentage there. And then the case fatality is of all those who developed COVID, how many died of it. So this is a little bit hard to read for those of us over 50, I'm sure. So over here, I just kind of pulled out those important numbers, the total from the bottom. So of all these facilities, this was impacting almost 3,200 patients. Almost 1,000 have been infected for an attack rate of 31%. That ranged from as low as 4%, so some of them did not have very many infections in their facility, to as many as 94%. Unfortunately, 146 deaths. And I've heard some people say, well, these are people who are going to die anyway. And I have to say that's not true. I mean, we all die sooner or later. But a lot of these patients could have lived many more years. Yes, most of them had comorbidities, but not all. So I sort of see every death as being tragic. And in this case, every death preventable if we could have prevented that infection. So case fatalities around 15%, ranging from 0 in facilities that maybe just had a couple cases to up to 50%. And you see in these facilities that have been going on for a while, it's really getting closer to about 20%. So I would say 15 to 20% is where it's probably going to be for most facilities once everything is said and done. So what about memory care units and geropsych units? So we've had 5 outbreaks so far, and we had one kind of early on, beginning of May, that was a geropsych unit, and then really didn't have any until the 28th of May, which was a memory care unit within a SNF. So I'm not sure why it took so long to kind of get into the memory care units, but now it's getting in there big time. Of those 2 facilities, they were, unfortunately, they were still kind of holding group activities, not really enforcing social distancing or regular masking, and both of them had a greater than 90% attack rate within those units. Now the next 3 that we had, and these all came in rapid session, this is about the time I called Patty and I said, Patty, we need to do something about this. We need to get this information out about memory care units to try to have people proactively start to enforce the social distancing and other prevention activities, because when it gets in there, it's just disastrous. So these next 2 facilities, facility A and B, when we went in to investigate, when they had a single case, they were still holding group activities. One of them was having a sing-along, another one we went in and all their residents were together in one room, all of them packed in within a foot away from each other, including symptomatic people and close contacts to the one case. So in the first facility, they initially found 3 infected, then another 6, and I think their 3rd round of testing is going on this week. So they right now have an attack rate of about 25%. In the second one, over the course of their first testing, they had 6 infected. And then the second round, which I just got the results from on my email just minutes ago, 21 additional infections. So they have about a 50% attack rate now. And unfortunately, depending on the type of facility, if they're shared rooms, if they're shared bathrooms, I think that facility is probably going to get close to a 90% attack rate, if not higher. And then facility C, which is within another one within a SNF, just on the first round had almost 50% of their residents infected. So I would presume that the case fatality rate in these facilities is going to be similar to SNFs, maybe not as bad depending on how many comorbidities the patients have. But I can say in this second facility here from 528, they've had 5 deaths out of 24. So it's running about 20%. And that's not done yet, not done yet by far. Now in assisted living, it's a little bit different. These are kind of different beasts in my mind. We have not had many outbreaks just due to the facilities. They're basically, you know, many times little apartments. Patients or residents tend to be in there by themselves unless they're couples. They tend to stay in their rooms. They're not going to be wandering as much, although they're getting depressed and wanting to socialize, obviously. But they're not requiring as much staff interaction. They don't require as much help. Maybe staff are not in their rooms as much, and they're generally healthier than residents of SNFs. So we did have several facilities with a single case in assisted living early on, I think in March and April, and those didn't lead to outbreaks. But we have had 2 outbreaks so far, one of them in mid-April. And in this case, this was an assisted living facility that had a census of 68. They had 2 patients develop COVID and die within days of each other. So that obviously got our attention, and we decided to send a team out to test. And we found 12 more who were infected, so 21%. This is distinctly unusual, and we think this may have been related to infected staff members, that they had a kitchen worker or 2 who were infected. So we're wondering if that was, you know, maybe transmitted through some fomites or something in regards to food preparation. We did send the team back 2 weeks later to test again and didn't find any more infected. So that was good, but several more people did die from that one. In the second assisted living facility, which we just responded to this last week, they're larger. They have a census of 110, 66 on the assisted living side, and then they have a memory care unit of 44. Very similar picture. They had 2 residents on their assisted living side who became sick and died within 2 days of each other. So again, we see that, we get concerned. All residents were tested. They found another 8 infected. All of those fortunately are on their assisted living side, so about 15% infection rate. And they're on the process of setting up their second round of testing. Now in this case, this is the first time that we've actually set up a COVID unit in an assisted living facility, because several of those patients were in the hospital, but several of them were still there. And one in particular had some behavioral issues, didn't really want to stay in his room, was continuing to walk around and interact, and we just can't have that. If people have COVID, they just really need to be separated out. So it was fortunate in this facility that they had another floor that was mainly empty. So we've helped them convert that into a COVID unit, and then given them some assistance for additional staff or resources to get additional staff to help care for those patients and monitor them appropriately. So we all have heard these methods to prevent spread of COVID. There have been recommendations from the CDC and from the state coming out for several months now. Symptom screening I'll talk about more on the next slide, but almost I would think all facilities have limited or canceled any kind of visitation or volunteer programs. Hopefully all of you have canceled group activities and congregate meals. I'm still surprised when I hear about facilities that are still doing that, because it's really hard to socially distance people completely. You have to be very, very vigilant if you're going to have any of these things and do it safely. For anything where it's in a community area, socially distancing, so keeping people at least 6 feet away, masking, cough and respiratory hygiene, hand hygiene, and then environmental cleaning and disinfection, all very important. But those numbers 3 to 7, so the ones that have to do with controlling the patients, can be very hard to enforce with dementia patients. So I'm hoping Jackie can help give you some tips on that later on. Now, symptom screening. Everybody pretty much has been checking temperatures on all people coming into facilities and on residents, screening for respiratory symptoms, sometimes checking oxygen saturation. And all I can say is that's just not good enough. This virus is a sneaky son of a bee that just comes in on asymptomatically, or people have very mild symptoms, and it spreads very efficiently. Initially, in the beginning of this outbreak, I sort of thought, asymptomatic transmission, not a big deal. I am a convert. It is a huge deal. We're seeing a lot of asymptomatic transmission, or what we believe to be asymptomatic transmission, or transmission that's occurring with very, very minimal symptoms. So we know that many patients present with less than classic symptoms. Cold and flu symptoms, so just having a mild fever, 99.2, 99.3, sore throat, headache, muscle aches, gastrointestinal symptoms. We had a number of patients who developed nausea, vomiting, and diarrhea, and the providers don't kind of recognize that and don't really respond to it quickly enough. It can also cause lack of appetite, weakness. We've had patients who've just had weight loss. Falls, so falls common in the older adults, right, and can be caused by a lot of different things, but we've had a number of patients who've gone in with a fall and ended up with a subdural hematoma or a broken hip, and they test them for COVID and they're positive. So it could have been the COVID that led to some weakness that kind of then led to the falls. The loss of sense of taste and smell is very specific for COVID. So if you see that, there's not much else that can do that. You want to definitely think about COVID in that case. But then there's other things that are even more difficult. So it might cause confusion, slightly altered mental status, which again in dementia patients may be hard to kind of tell. Neurologic symptoms, we've had some patients who have developed strokes and tested positive for COVID. So that's another way it can present. Again, mild behavioral changes, so increased agitation, sadness, reduced activity. It's just really difficult. So you have to be vigilant for any change in the status. You all know your clients, your patients the best. And if you note to change, I would say test early and don't always believe a single negative test. The test is not 100% sensitive, and we've had a number of occasions where we were convinced someone had COVID and the first test came back negative, and we'd say, well, wait, test them again in a couple of days, and then it'd come back positive. So I would say don't take a single test negative. You may want to keep the person isolated and retest them in a couple of days. So what I would say for you in memory care units and assisted living, it's not a matter of if, but when you're going to have to deal with COVID, because it will come, whether in a staff member or a patient or a resident. So what do you do with a resident who has COVID symptoms? That's considered a PUI, a person under investigation. We think they may have it, but we don't know yet. You want to try to get that person in a single room. If they're in a single room already, just keep them in there, but you want to make sure they're not going out and about. Now you have several options. You can call us at 714-834-8180 to arrange a quick testing. We do have a 45-minute PCR. Or you can send to a commercial lab if you've contracted with a commercial lab, but please don't send it if the commercial lab is going to take 5 to 7 days to get your results. That's just too long. We'd want to have results as quickly as possible. And then in having staff to deal with the patient, you would want to use full personal protective equipment, or PPE, including the gown, gloves, face shield, and mask. And make sure that that door to the room is closed and that patient is not coming out of the room and engaging in any activities or going to communal meals. So don't let that patient out, even if the symptoms resolve. Sometimes we've had patients who spiked a fever, had cough for one day, and then they look fine the next day. Don't believe it. Don't believe it and keep them in isolation until you can get that test result back. So as I said before, if initial test is negative, but you have a high suspicion, keep them isolated and retest in 2 to 3 days. So this is the CDC's kind of guidance for putting on and taking off. So putting on is donning, taking off is doffing. PPE. I don't really want to go over this right now because it's very important, but we actually have, the county has contracted with a group of infection prevention specialists called Expert Stewardship, and I'll have one of the members of that team on next week's webinar to kind of talk about this a little bit more, either show a video or do a demo, because this is very, very important. I can just say right now, the most important things, everyone is wearing masks or should be wearing masks, and I just don't think a lot of people are doing it correctly. So they'll spend some time talking about that. Make sure the mask covers your nose and covers your mouth and isn't dropping down over your nose or dropping down onto your chin. Hand hygiene is critical. Before you put your mask on, after you take your mask off, don't constantly be touching your mask and adjusting it, because that's when you're going to get your hand contaminated and then getting infected.
Enter your meeting ID.
So what do you do with a staff member who has COVID symptoms? They're also considered a PUI. If they're at work, send them home immediately. If they call in from home, tell them not to come into work and arrange testing as quickly as possible. There are some community sites where they can go to. They can come here to get tested with us. So I'll talk about some more of those options in a few minutes. But do not let the staff member back to work before the test result is back, even if they're feeling better. Again, if that initial test is negative, but you have a high suspicion for COVID, you want to just keep them off work for a full 10 days and consider retesting in a couple of days. So we had a staff member at a SNF who developed loss of sense of taste and smell. Initial test was negative. I said, don't let them back. Do not let them back. That's got to be COVID. And it's just the first test was probably falsely negative. Now, if you have a staff member who does have confirmed COVID, you should be reported to us. And the staff person can return to work when they meet the CDC time-based or symptom-based clearance. So the time-based clearance is if someone has no symptoms at all, they should be off of work for 10 days. That's the time-based. If they have symptoms, they should be off for at least 10 days. But by that 10-day time, it should be that they've had no fever for 3 days and their symptoms should be improving substantially. If they're not substantially improving, I'd keep them off longer. And many places just choose to keep people off for a full 14 days, if not longer. We do not advise the test-based clearance, which I'll talk about in a few minutes when I talk about clearing residents. And this is the CDC website for guidance on that. So if you have a resident with COVID and you plan on keeping that patient or that resident at your facility, we recommend they be isolated or separated from other residents for 3 to 4 weeks. They can share a room with other COVID positive patients if need be. And as I mentioned before, it's really best to establish a COVID unit if you have multiple patients. So that, again, has a separate entrance and exit for staff. Dedicated staff, ones who are not going to other parts of the facility during that work day. They can work in the COVID unit one day, then work in the rest of the facility another day, but not on the same day. You should have separate break rooms and bathrooms for staff, and then have some kind of physical barrier that keeps other patients out and COVID patients in, whether that be fire doors that you can close, or a lot of places are putting up a big plastic sheet like they use for construction, just something to keep from the negative patients coming in, positive patients going out. The staff would put on full PPE and wear it the whole shift. They don't need to change their gown or their face shield between patients, just gloves. And if the COVID unit is fully contained and separate from the rest of the facility, then you can let those patients go out of their rooms. So I can imagine how depressed and many of these, and I've seen them, go to a lot of these facilities, and these people have been on lockdown without family members visiting, without being able to leave the facility for a long time. And then if you put them in their room for another 3 to 4 weeks, just horrible. So if you can have a COVID unit, at least you could let people out and about, out of their rooms. But if you have a single patient, it's really more difficult. You can't let that person go out and about. They really need to stay in their room, cannot leave, and you have to have a staff member use full PPE when taking care of them. So it's really time to start thinking about what you would do in your facility. And if a COVID unit is not possible, you need to start thinking about where you might send patients, because hospitals are not going to want to take these folks if they're not sick. And in a substantial proportion of them, we go in and test, we find a lot who have no symptoms at all, but they're COVID positive. That doesn't mean it's a false positive. You watch these patients, and the majority of them, probably about 2/3 to 3/4, will develop symptoms. It may take a day, 2 days, 3 days. We've seen some people take as long as 2.5 weeks before they develop symptoms after a positive test. So there's really no treatment for COVID. As many of you know, Plaquenil is not recommended, and actually the FDA just removed the emergency use authorization for that. But you would want to review their end-of-life wishes. When you know that someone has a disease that has a 20% mortality, and that 20% mortality may occur within the next couple of weeks, you want to find out what that person would want to have done, and whether they'd want to go to the hospital or not. Now, you would need to monitor these patients closer than your typical residents. You'd want to check them at least 3 times a day, more often if you can. And that would include vitals, so doing temperature, pulse, blood pressure, and respirations. Check oxygenation if you have a pulse oximeter available. You can get some very inexpensive ones, about $20 on Amazon, if they're still available. I heard they were kind of sold out. And then review them for symptoms of COVID. If they're complaining of shortness of breath, cough, GI symptoms, weakness, altered mental status. And if the patient wants to go to the hospital, send the patient to the hospital if symptoms worsen, or if they don't want to be on the hospital, if they're on hospice, then arrange for comfort care. So when can you take a patient with COVID out of isolation? So for clearance from isolation, we do not recommend the test-based strategy of the CDC. And that test-based strategy is getting 2 consecutive negative PCR tests 24 hours apart. The problem with this approach is that it can take a long time to get 2 negatives. Our very first facility, the Geropsych unit, is trying to do that, and we're seeing that it takes 4 to 6 weeks to get 2 negatives. And those continuing positive in those patients who have already recovered from symptoms or never had symptoms doesn't really mean that the patient is still infectious. It means that there are bits of the virus still in their nasal cavity. And it's really hard to tell when is the exact end of an infectious period in older adults. Now the CDC says 10 days. They say 10 days for everybody. I just don't believe it. I mean, older adults are not the same as younger adults. We know that older adults can shed viruses longer. So we have from the very start recommended a much more conservative approach for release from isolation. We advise 3 to 4 weeks separated from COVID negative patients. Their symptoms should be gone completely or significantly improved before they leave the red unit or the isolation unit. The reasons for this conservative approach are several. First, as I mentioned, viral shedding is thought to be more prolonged in older adults. That's true for influenza. It's likely to be true for COVID as well. Then if you're dealing with a memory unit, the patients are going to have cognitive impairment. They may not be able to really practice respiratory hygiene, hand hygiene, social distancing, all things that are important in that convalescent period. Then we have seen some asymptomatic COVID patients develop symptoms, as I mentioned before, at about 2.5 weeks. So imagine if you released someone from, if they're asymptomatic and you had them in their COVID unit for only 10 days, as the CDC recommends, you release them out to the regular unit and then you develop symptoms, they're going to expose everybody and you're going to have a huge outbreak on your hands if you don't have one already. And then just the very high risk nature of this population, where we're seeing these attack rates of in a SNF of 30% and in memory care units of up to 90%, and then mortality is running 15 to 20%. We really want to do everything possible to try to protect those unexposed patients and prevent them from getting it. So what about the other residents who may have been exposed to COVID? So a close contact is defined as someone who's been within 6 feet of a patient for 15 minutes or longer. So in that, the second of the new outbreaks that I said, when we came in and we saw everybody, like a large, all their population were all bunched together in a main room. They went from having 6 to 21, and I'm certain that was from all that really close contact, and we couldn't tell who was within a few feet of the cases or not. We know from at least the SNF experience that the roommates, so if it's a shared room and one of them gets it and the other one doesn't, the one who didn't get it has a very high risk of developing it. I would say 50 to 75%, but it could take 7 to 14 days before that shows up on a test. Other high-risk individuals, aside from just the close social contacts, is someone who may have shared a bathroom, because we know that bathrooms are a way to transmit the virus as well if they're not like cleaned after each use. So you definitely want to quarantine those roommates. They're probably the highest risk, ideally in a room by themselves with the door closed and healthcare worker in full PPE. Test them at 7 and 4.
Helene, we've lost your audio.
How long ago?
There you go. Just about the last 2 seconds.
Okay. So as I said, you want to, those roommates, you want to quarantine them, test them at day 7 and 14 after their last contact, and then you can release them if both of those tests are negative. So quarantine means that they stay in their room. There's no interaction with other residents. There's no wandering around in a yellow unit. You can create a yellow unit or quarantine unit if you'd like. Again, that doesn't mean the patients are free to wander around, but at least you can dedicate staff so those staff know they're using full PPE and keeping all the doors closed and trying to keep those patients contained in their rooms. In some cases, it's really hard to tell who's exposed and who's not. If patients, in the last one that we have, where we already have almost 50% of the patients with it, I think there's really nothing we can do. All of them are going to end up with it. That whole unit now is going to be a yellow or red unit, unfortunately. So after a case of COVID has been detected, generally there's multiple weekly rounds of testing done on the residents who are negative, and that how many depends on how many new cases are found and whether there's ongoing exposures. There are recommendations for SNFs from the California Department of Public Health, or CDPH, and CMS. They recommend testing residents and staff if a case is identified in either a resident or a staff member, and repeat those weekly in both until 2 sequential negative rounds of testing. They do have a caveat: if you don't have enough capacity to test the healthcare workers all the time, then they said focus on those who work in the unit where the COVID resident was. So these recommendations are for SNFs. Should they apply to other congruent settings like memory care? I would say definitely in memory care. This is an extremely high risk area. I would say for a single case in either a staff member or resident, we would recommend testing both of them and repeat it at 7 and 14 days. But in an assisted living facility, that kind of widespread testing is probably not necessary. It really depends on the situation. And in that case, you would consult with us to try to determine what's best to do. Now, surveillance testing. So this is done not in an outbreak setting, just as kind of routine. Surveillance means you're looking for disease. And there is surveillance testing recommended for SNFs by both CMS and CDPH. But I'm not aware of any recommendations for RCFEs, ALFs, or memory care units. But we think that some testing is a good idea. So CMS and CDPH say for a SNF that they should test all of their residents and staff at baseline. Not quite sure if that's really necessary in these other settings. CDPH then recommends that for SNF staff, at least, there is some ongoing surveillance testing in SNFs. They recommend testing 25% of the staff weekly, with each staff member being tested at least monthly, and they recommend testing new residents on admission, and then again after 14 days prior to removing them from quarantine. So what do we say about RCFEs? It's kind of difficult because there's not firm guidance, and we're just learning. We're just starting to really deal with these in memory care units and ALFs. We've got a lot of experience in SNFs, but now we're starting to get experience in this other phase, unfortunately. We would say consider doing baseline testing of high-risk staff, so your staff who work in your memory care unit or staff who have a lot of direct patient care, if not doing all staff. Now, some corporations are jumping on board and doing a baseline testing. We're fine with that. But we realize that capacity is limited, and I'll talk about that more in a few minutes. We would say strongly consider testing a subset, whether that be 25% or whatever you can handle, of staff weekly or on some regular basis. And it's best to focus on those higher risk staff, so the ones who have direct patient care or contact, who work in the MCU, or who work at multiple facilities. Now, we saw in the SNFs that was a way that outbreaks were spread, that there's a lot of staff sharing among SNFs. I don't think there's as much among ALFs, but there's probably some. So if there's an outbreak in one facility, that oftentimes would be brought to another facility by the staff members. So that's another sort of group to look at. We definitely would recommend to test new admissions at baseline if they haven't been tested in the hospital or prior to admission to your facility, and then after 14 days, and separate them from the rest of your population until that time that 14-day result is back and is negative. In addition, we would also say strongly consider regular testing of certain high-risk residents. So if you have any patients who are on dialysis, anybody who leaves your facility on a regular basis for frequent medical appointments, that's the other kind of person that may bring it back in. So consider testing them on a regular basis as well. Now, testing has been a large focus for us the last couple of weeks, as we had 27 SNFs and we were trying to do all the testing ourselves. We realized that is not possible. So we started to encourage facilities, and also there's a state mandate for the SNFs to have contracts with a lab that can do the testing. So if it's something you're interested in, you should look for a lab that can bill third-party insurance, and that maybe can bill HRSA for uninsured patients. If you find one that has a comprehensive billing department, that should eliminate charges for your facility. Try to get one that uses CalReady, the electronic reporting, so we can get those results of those positives and not have to try to track them down ourselves. Hopefully the lab can make the results available to you electronically in a manner that makes it easy to keep records, and ideally has a turnaround time of no longer than 3 days. Best is within 48 hours. You may want to consider doing in-house testing of staff if possible, because that will reduce the burden to your employees. They're not going to have to make an appointment. They're not going to have to travel to a test site. I've heard some of them having to wait an hour in line to get tested. So you might have to kind of look at a couple different labs and have contracts with them to be able to fulfill this. Create standing orders for patients and employees, and have medical staff observe or conduct the specimen collection. You can do self-collection of some of these. So here are some community testing resources for staff. So there are the CVS Minute Clinics, which are available for asymptomatic staff who work at healthcare facilities or who take care of older adults. They will bill insurance. They will bill HRSA, so no co-payment should be required. You can make the appointments online or call this number. I understand they are kind of backed up. So right now, all the SNFs are trying to fulfill their mandate from the state to test all their staff at baseline. So I've heard that for some of these locations that they may be 4 to 5 days out. So you really have to kind of look. There are a lot of locations available, 16 of them in Orange County. So you may just have to kind of look around and see who has availability. Then there's the OptumServe sites, which are run by the state. There are 4 of those in Orange County. Again, you make the appointment online. It's by appointment only for both of these. There's really no walk-ins. And again, they're both for asymptomatic, both free of charge. No co-payment should be needed. Now for commercial labs that you may want to look at, this is a table that was put together by Donna Fleming, our former chief of operation. Gives a little idea about contact people and what the details are of the billing, et cetera. I know that UCI lab right now I think is maximized. They're getting kind of impacted by all the requests. And this is not by far an exhaustive list, but and it doesn't imply that we're endorsing any of these labs, but these are just some that you could start to look at that at least we think are pretty reasonable labs and you know, can deliver for the most part on what they say they can. If, but when. So at this point, if you have not already tried to reduce resident interactions and enforce social distancing, masking, and hand hygiene, you need to do that, because sooner or later you will have a case in there. And do you want to have a 25% attack rate or 100% attack rate? I would say everyone should implement the expanded symptom screening for COVID in both residents and staff. So not only asking about the cough and fever, but asking about the GI symptoms, asking about some of those less common symptoms, the loss of sense of taste and smell. Start now looking for a commercial lab to contract with if you don't have one already. And if you have one already, are they able to deliver in a fashion that you would like them to deliver on? Because you would like to have a lab that could potentially deal with regular staff testing and testing of residents as needed for contact investigations, outbreaks, or for symptomatic. We can help some, but we just can't do it all, not with 700 facilities. We just can't. Think about what you want to do with your COVID positive residents if you were to get any. Do you want to transfer them out or keep them on site? If you transfer them out, where are you going to transfer them to? Think about that. If you want to keep them on site, where will you keep them and who will take care of them? You want to ensure that you have an adequate supply of PPE and do training on donning and doffing, because a lot of your staff may have never had to do that before. And we can help with some trainings on that. Like I said, next week, I think we'll have someone from Expert Stewardship talking about PPE issues. And then if you're not doing it already, make sure you clean frequently touch surfaces often in the memory care unit and other areas of your facility if patients are out and about. So the CDC does have some guidance on that, and I think Jackie will kind of expound on this a little bit more, but how can you kind of keep your residents as happy as possible, as healthy as possible, but not interacting with each other as much as possible? So there are different ways to approach this. One facility we went in that had a kind of a central gathering area and then 5 wings, then closed off their wings and would only open up one at a time to allow the patients to come out into the common area and put X's on the floor to make sure that they were keeping separated. So I'll kind of leave Jackie to talk about that. And just wanted to finish up by saying that going forward, we can help with some advice in setting up commercial lab contracts if needed. Donna Fleming is available by email or phone, but she would ask that you first make an attempt by contacting some of these labs yourself. We will continue to help with outbreak response and advice, but we're not going to be able to do all the testing. We may be able to offer 1 or 2 rounds of resident testing if it's needed and if our capacity allows. That sort of changes day to day. We will always be available to test PUIs, so those residents or staff using our Gene Expert 45-minute PCR test. So you call the number here to schedule testing for if you have symptomatic staff, or to schedule specimen pickup for symptomatic residents. And then our infection prevention consultants are available for questions, advice, or training. Facilities with active outbreaks would be the ones that prioritize for in-person services, so coming for a visit or doing some trainings. But questions via the hotline or by the email are welcome for all, so please take advantage of their services. A final thing is some people are saying, well, when can we reopen and when can we restart activities? And I would say not yet. We are definitely seeing community transmission is not reducing and is likely to increase once businesses open up more fully. Most facilities have not been able to operationalize the regular surveillance testing for staff. I think once we can do that, maybe we'd feel a little bit more comfortable, but we're not there yet by far. We saw that facilities with group activities are having 90% or higher attack rates. And even with the lower attack rates, case fatality being 15 to 20%, you really want to try to avoid that. So the timing is really unclear at this point. I would say stay tuned. And that's all I have, Patty.
Well, thank you so much, Dr. Calvet. That's quite a bit of really important and useful practical information. I'd like to have us transition to Dr. Jacqueline DuPont to talk about how can we deal with the human side and the emotional side and the activity side of caring for people who are in memory care during this really unprecedented episode. Dr. DuPont.
I'm going to take off the share on my screen now, right?
Yes, take off share screen.
Okay.
Dr. Calvet, that was amazing. The information you gave us was so critical at this time. I know a lot of us own, operate, work in assisted livings with memory care. One thing that's kind of not as clear is in California, most memory cares are now assisted livings. They used to be skilled, but they've transitioned into assisted livings. So a lot of her information is so critical because the assisted livings don't have the same training as she mentioned. And in smaller facilities, you know, our 6 beds, we really are all memory care units, really. Over 50% of our clients, usually, you know, residents have memory issues or cognitive impairment. And it's really critical to pay attention to all of her issues. But how can we be advocates at this time as owners, operators, caregivers, whatever our case is? There are so many issues to look at. And one really is the older adult with cognitive impairment, and how do we really do this infection control in a way that isn't threatening to that? And so one issue I get asked a lot is, how do you handle the mask issue? And the mask issue for our employees wearing them and the older adult being fearful of them or not knowing who you are anymore is really just putting your name tag a little larger. If you don't have name tags, maybe get stick-ons, making it larger, making it seen, telling them ahead of time, hey, I'm putting on my mask, I have a mask on, I'm Jackie. I don't know if you remember me, but you don't have to say that, but you know, I'm Jackie, and just wanted to say hi today. And they'll say, I know you're Jackie, but you know, you just go along with it. So I think just repeating your name, telling them what the mask is for, it's for safety, for their safety and our safety, is really critical. Have we seen older adults wearing masks in memory care? No, not really. And I'll get into that issue later, but they're having a hard time with it. They're feeling, a lot of them, claustrophobic with it. If they're willing to do it, you know, offer it for sure. Most are having a hard time with the string, the elastic, and it's becoming a little bit of an issue, but if you can handle it, at least offer it. What are some best practices? Let's start with that. We know the state has asked us to put a station out front of our door with some visitor warning notices, such as please don't visit at this time, please call our administrator and we'll set up a FaceTime, or you can actually talk through the window, whatever you're doing to keep people out. What about our independent contractors, our musicians, our wonderful memories in the making, all the wonderful things we do? We need to those have to be on hold. They're not saying they have to be, but I would suggest highly that you don't allow any independent contractors in. For a while, I didn't even allow home health unless it was something really, really important. We didn't allow physical therapy. We limited physical therapy, home health, and hospice only for end-of-life hospice. So then we're doing all the bathing. Hospice isn't, because it's just bathing aides coming in, it's another person. Limiting the amount of professionals coming in at this time is a good idea. Another good idea is having these wonderful nail salon ovens, I call them, but they have these great washcloths. You roll them up, spray them with hand sanitizer, roll them up, wet them, and then hand those to the residents throughout the day to clean their hands. They aren't great about washing their hands. So we not only have to think about washing our hands, we really need to think about washing their hands more often, before meals, all the time. What's another best practice? In smaller facilities, I'm seeing everyone washing their dishes by hand still. That's got to stop. We've got to use the dishwasher. We have to get those stronger temperatures. What are some best practices when your resident goes out to the ER? Well, you have to ask, please test them before they come back. And they will do that. So we've been doing that for a while, and they've all been very helpful. First they asked, and of course we said yes. But now anytime someone maybe has a fall and went out, just say, could you please test them before they come back? Now, could they get it in the transportation? Yes, but at least we're testing more. We are doing what Dr. Calvet has suggested. We're doing randomized in the smaller facilities employees. So we did about 20%. And then we're doing randomized residents and just picking I think we've picked about 30%. And that's been really helpful. But one problem I seem to be having the most are the vendors, the hospice, home health, and PT, OT, and speech, are they on board with what we're on board with? We need to communicate, especially with hospice, because some hospices are saying, let's just not test anyone. You know, they're hospice, comfort only. So a lot of them have refused with me. And I said, I'm so sorry. It's not only about this older adult, it's about the other older adults that live there. And we must test hospice patients. So please try to call your hospice vendors and say, let's all be on the same page and agree that if someone has symptoms, has a temperature, whatever it is, I know that can happen with death and dying. However, at this time, we need to be a little more cautious. So that's one thing I think you really need to talk to them about. Another thing that is so important to talk about this time is our governor's incentivization to place older adults with COVID positive into smaller facilities. He came out with an announcement on April 3rd and 4th. Many owners have taken the incentivization money, which is $1,000 a day. I just want to be real honest about this because it's something we need to talk about. Most are memory cares in San Diego. So I have spoken to 9 of the owners. Just thought I should, before I get here. And they're having high death rates, like half of their people are passing away. Yep. And I realized the governor probably had a great suggestion for this. I mean, maybe he was given information, but I feel it is not the right place for us as memory care owners to take anyone from a SNF. He's calling them mild cases. There really are no mild cases to go.
Right.
No, but it's popular because you're getting $32,000 a month. And I just want to give you 3 reasons why not to do it. Number one, we have a cocoon. Most of us have worked so hard on our infection control, on spraying down our doors, on the nail sprayers. I have a fogger. I can go over how to get a fogger. A fogger is great. It's a great way. to clean up and really spray the whole place for infection control. I've done that 3 times. So those things are so critical, yet the cocoon's going to break open if you bring in that one case. I know you think, oh, it's no big deal. I talked to this one owner and she said, I really didn't think it was a big deal. I did the whole room. I covered up the vents. I sprayed it with Lysol. I trained all my caregivers and it didn't work. And, you know, it was such a mild case. And now I have 2 employees suing me because you know what kind of environment we live in. This is a very litigious field. Do you not think your employees are going to have some work comp, some issue? Then you have the other families who she's getting sued by 1. So, you know, I just think it's a bad idea. So those were my 3 points to just kind of don't take those cases. We're not set up for it. And where should they go? Because I don't want to just be a problem announcer. Problem solving is important. They probably should go to a VRBO, a hotel room. There's lots of great, for $32,000, we can hire a caregiver that's specially trained. But isolating those people, I just talked to a cute couple that was at a CCRC in Orange County that had positives, and one of them tested positive. So they went to a hotel, a very affordable hotel, got a caregiver. They really aren't that symptomatic, just, you know, a cold. They've done really well, but they didn't even want to affect others. So I think there's ways in assisted living that we can think outside the box where we don't need to go into memory care. So that's just my thing on that. With the dialysis patients, she's so right. They are going out to a unit. You can ask for the dialysis to come in because we're assisted living, it's their own home. I have done that, it's working. Or when they come back, that would be a resident that she has identified in that 25%. So we identified anyone who's gone out. And even if they're going out for, let's see, inpatient psychiatric, anything, outpatient psychiatric stopped. Some facilities are still sending people out to outpatient psychiatric. I think it's probably a bad idea. You just keep everyone inside for a little longer, like she's saying, until we hear. But what are some other best practices for keeping them inside their room? That's the hard part. I think Target and Walmart have these fold-up tables, and they're just super simple. You know, I don't know what you call them, card tables, whatever they are, fold-up small things, because you don't have a lot of hospice tables, hospice bedside tables anymore. So those tables are, you know, $15, $20, just to kind of spread everyone around the small home in about 10 feet away. And at first you're going to see some resistance because they're going to say, you know, one lady cried a lot. And I went to her and said, you know, Mrs. Smith, this is not a punishment. This is because we've got this virus and we're really trying to distance ourselves. Just explain it over and over again. And after a while, everyone gets it. You know, then they get their little spot. And now you can't move them. Now they love their little corners and make it positive. Put a little flower there. Cut a little flower, put in a little vase, stick it there. This is your own special table. I took their memory placemat, put it there. This is, oh, now your placemat's right here. And, oh, is that your family member? And they talked about their picture of their daughter. So just make it special. Because if you don't, they might feel, you know, like you're putting them in a corner, which we don't want that feeling at all. For ideas, I am working with the homeless as well. We've come up with, at Illumination, some kits that we're giving them in their room to keep busy. Some great artwork. It just depends on the level of the cognition. But if they're a mild cognitively impaired individual, they might want very simple puzzles are really working. And, you know, puzzles are pretty sold out, so you've got to find them. You got to get to Walmart right away or to Target because they're running out of them. But the simpler ones that aren't demeaning or childlike, they're loving those. But bringing constant stuff into the room if you do need to isolate someone with symptoms is really important. Music is so important. And because we can't have our music therapist in, now one thing I did do is I took the contracted music therapist and made them an employee and said, I'll tell you what, if you'll only come to my facilities, I'll pay you as an employee. That's acceptable. But when he was an independent contractor going to ABC all over Orange County, that is not acceptable. But we started the headphone program. Now every resident needs to have their own headphones because we don't want a cross-contamination issue. So they're very inexpensive. You can find headphones now anywhere. And just ask for donated iPods. I've had many people donate their old iPods. Fill up their favorite music, put on their headphones. That's really helping them feel less isolated. Other issues I've come up with in larger facilities, larger memory cares, are really doing, if they have a room that is large enough, just setting up stations of activities in that room, of things for them to do, making sure they have a TV. You know, we don't like TV usually. We preach against TV in memory care because it's zoning. But you know what, at this time, let's probably get them a TV, inexpensive TV if we can, and hook up cable that wasn't on before. That's helping a lot. One day, a couple weeks ago, cable went out, and that was just heck for everyone. So I hope I've gone over some issues. I did get a testing company, not one of the ones Dr. Mentioned, but I found one in the Valley, and they came out and they took all our insurances. They don't take Kaiser. So I offered to pay for the Kaiser ones just because in my random sample, I needed to make sure, you know, that if the family wasn't going to pay for Kaiser, I had to. So, because otherwise it's not going to be useful to us. I'm trying to think of other things. The mask issue, the fall issue that she mentioned is so critical. And these symptoms are not the same in older adults with memory loss, especially with older adults in general, but then we have dementia to complicate things. So we have to be very, you know, vigilant with our medical directors or visiting doctors that we test their urine, make sure this isn't a UTI, but also test the whole person, look at the whole person. They all matter. And I really can't tell you enough to not take the COVID positive patients for the money. It's just not worth it. In the end, it will become your biggest nightmare, just talking to these other owners. So I hope I've answered some of the ideas that they talked about. If you need any supplies or anything, I've mentioned the ovens, the fogger, the lab. I'm happy to share all of it. I'll put a slide together for Patty and she'll have it. But thank you for asking me to share today.
Thank you so much, Dr. DuPont. We really appreciate it. I have a question for you, Dr. DuPont. If most of the residents are amenable to wearing masks, if you could make it kind of a game or kind of fun, for that one resident that doesn't seem to want to wear it, what else could we do that that would either help them want to wear it? Have you had luck with pretty masks or any particular successes with people that are really reluctant to wear the masks?
Yes, I have. So if you can ask what school they went to and then ask the daughter for like any cheap t-shirt, my good friend will make like their school. So I got an SC guy who was just not going to wear that mask. He ate it, but when he got his little USC on there, he put on that mask and now he won't take it off. You just got to think creatively of what would make them happy to wear the mask. They aren't loving the plastic paper ones, I think just because it's uncomfortable maybe, I'm not sure. If they have COPD or any kind of breathing issue, it is tough with the mask. That's what I'm seeing the most, but.
That's a great idea, having their emblem from their school on there. That's a great idea.
An old t-shirt or anything older, like even a family picture on an old t-shirt, you can cut that and make that into a mask. So anything positive that they'd relate to, I think is helping.
Great. All right, so I'd love to open this up for questions. Down at the bottom of your screen, there is an activity and icons, and you can raise your hand there. You are welcome to unmute yourself and kind of raise your hand physically and ask your question. And you should be able to, okay, here's one from chat. This is from Mickey. Let's see. For Dr. Calvet, is it true that less than 11 residents with positive cases, it is not on the Orange County Health Department website, although you may have that information? How can we find out this information for families we're helping with placement? So Mickey, did I get that right? That there are 11?
Yeah, I actually, I'm not sure. I know that's how it was. I think that was for city-based though data. And I frankly haven't had time to look at our countywide data often. But as one place you can check for facilities, at least for skilled nursing facilities, is the CDPH website. So California Department of Public Health posts any cases in residents or staff of facilities. And I can get Patty that link. But that's just for skilled nursing facilities. So when you're talking about assisted livings, standalone memory care units, or the RCFEs, which are licensed other Department of Social Services, I don't think there's a similar list for that.
Okay, so there may not be a way to check whether or not there are reported active cases of COVID in an RCFE. You're going to have to rely on people self-reporting to placement agents and families.
I think so. I mean, we should know about those, but sometimes they don't get reported to us. So I am not sure, actually. You know, this whole interaction with the RCFEs is kind of new to us. I mean, it's not a service industry that we typically have interacted with. So we're struggling. I mean, we finally got a list of the RCFEs from Department of Social Services. I don't know if it's accurate. We tried sending out some communications early on, like in March and April, and it's been kind of a struggle.
And so there is no regulation of which you're aware for RCFEs to report active infection.
We do have to report to the families, because I did talk to a couple of regulators last week, and if there is an employee positive or a resident, any memory care, assisted living, or RCFE has to report to their evaluator. And the lab, you have to kind of check with your lab to make sure they reported the way she said. It's called the day, what is it called again? You said it, Dr. Calvet. What's the name of that? Is it CalReady?
CalReady, yes. Uh-huh.
And so most labs, though, are reporting the CalReady. I asked ours.
Yeah, yes and no. I mean, don't be surprised if you see a day in Orange County where we report 500 cases, because there's backlog of cases for one reason or another that haven't been reported to CalReady. That's why you see this variation, where one day we may be at 150, then we're at 250. Oftentimes that's a reporting thing. It's not a real variation. And yes, you are supposed to report to the OC Department of Health as well. Some people don't know that, though, and we find out other ways. Or, you know, as Dr. DuPont said, we've just seen some disastrous outcomes in the 6-bed RCFEs, where it's just wiped them out. And not only the residents, but the staff as well, just getting sick from that and things like that. So sometimes we don't hear about these until kind of too late. It can just really spread very, very fast. One other thing that you didn't touch on, but I wanted to say, because I thought about it while you were speaking, is I have been into a couple of these units where there are, in the communal areas, different toys. So a baby, and they said, oh, our residents love to carry this baby around. Wonderful, but you need to get them their own babies. You can't have one baby to share amongst all the people. And if you let them come into common areas, you're going to have to just do it in smaller groups and make sure they're spacing out. So any kind of things that are in the common areas, jewelry, clothing, puzzles, books, I would get rid of all of those and try to get, if people like something like that, try to get one for themselves to keep in their room.
Yeah, for sure, in the room. One other issue I was thinking of when you just said that was communication with the families. Believe it or not, there have been reports across the country where when you have that positive, you need to communicate right away. And so many facilities did not in New Jersey and New York and all over. So that communication, I highly encourage. I've been sending an email about every 2 weeks, just saying, this is what's going on. This is our plan. Please continue not visiting through the window, going on the porch, just keep updating them, because they may forget and just walk in, or they you know, they need to be comforted. I think the families are really struggling at this point. So we just need to keep that constant communication. And when you get that case, it's so critical to be honest. I know everyone is, but you know, just making sure we notify everyone, because there could have been a visitor on the porch who was immunocompromised, who had cancer, and you never know. So it's super important that everyone knows.
And I think they're doing a good job at that, actually, because night before last, one of our neighbors texted me and said, oh, I just got a notification from my mom's facility that they have a case there. And I'm like, well, I haven't heard about it, and I should hear about all of those. Sure enough, the next morning, there was a report. So the families knew about it before I did, which is a good thing. And in almost every facility we're going into now, they've already notified families, unless it's a very large facility, and they're in the process. They're in the process of making the phone calls in addition to sending letters. And I think the more you can communicate, the better.
Other questions or thoughts? I had a question about heating and air conditioning vents. And this may really show that I am not a scientist, but 25 years ago when Legionnaire's disease was being spread and it was a major health issue, it was found that disease transmission was through air conditioning vents and the vapor. Is it possible that the COVID virus could be doing the same thing in congregate living?
Yeah, good question, Patty. I don't think so. In that case, it actually, Legionella is in the vapor. I mean, it's a water-based bug. So in this case, we think it's mostly droplet. Now, there may be cases where people can aerosolize it for certain things if someone's getting a nebulizer or they're being intubated. But in most cases, if you have an up-to-date filter on your HVAC, your air conditioning system, that should be sufficient. So I won't say it never happens, but it does not seem to be an issue. It's mostly the person-to-person thing. So it's really, keeping those people separated. And Dr. DuPont, I don't know, you didn't really say, are things like Zoom or FaceTime helpful for those with dementia? Can you hold like group activities via Zoom with them in their rooms?
Yeah, we're doing that. And also, when you have that form on your door, I highly encourage you to put a phone number that they could call to do FaceTime with their loved one as well. I forgot to mention that, but yeah, we do. We have volunteers from, everyone's trying to help, I think, and UCI students, students from many high schools who are making really wonderful videos for us. One lady, Dina Sherman in Calabasas, she reads to them a funny book and they crack up. I mean, we have videos of the video. Early on, Dina started reading to them, and she will read to any of you, or you can download her YouTubes, and they really think those are funny. So if you just put a laptop maybe on the dining room table and then kind of keep people spread apart and turn it way up, they love that. But Zoom singers are beautiful. One girl, what is her name? She's from J. Sarah. She sings once a week, does a little concert. And I'm trying to.
Wonderful.
So many.
Now, I would just warn though, if you have musical things, you can't have people singing along, because singing is essentially the same as coughing, and there have been many outbreaks associated with choir practice. So if you're going to do a thing like that, I don't know if the resources allow for each individual to have an iPad in their room, but you definitely do not want to have sing-alongs or singing activities. So if there's music is going to make them sing, don't do it.
Interesting. Okay. What about transmission of droplets onto surfaces? How long is the virus truly active?
Yeah, that was, it depends on the type of surface and the environmental circumstances, but that's why we recommend to do frequent environmental cleaning of high-touch surfaces. So any handrails, doorknobs, things like that. In nursing homes, we're encouraging, when they're having outbreaks, to do it every 2 hours. So that's why I had on my slide at least 3 times a day, or more often if you're having an outbreak, because it's really hard. It's hard to tell. There's just too much depends on it. It doesn't last forever, okay, but hours to maybe a couple of days, yeah, possibly.
Okay, and we've had a request, Dr. DuPont, when you put the information on your slide to share with folks, would you include the name or the website of the woman who does the reading? There's a lot of interest in that. And just so you all know, we will send you a PDF of Dr. Calvet's slides and other information. And we have a follow-up to this discussion on the 24th at the same time. Please do RSVP with Jessica if you haven't already. But as you put some of these things into practice and have a chance to try things out or look into some of these great suggestions, you'll have the opportunity to come back and talk with both of these experts and ask more questions or bring back some things that have really worked well. And that's really the beauty of this interactive kind of discussion. What other magical things are you doing, Dr. DuPont, that that really help the residents kind of calm down with this? What are your staff members doing that really allay fears?
Well, I have to mention, Dr. Calvet, that's such a smart idea to not have the sing-alongs. Oh my goodness. I myself. I like the calming. I have to say, if you can get an Alexa or something, the calming music seems to be better even than the girl who's singing from J. Sarah. I can't remember her name right now because she sings every week. She sings pop stuff, so they don't even know what it is. So that's good. They can't sing along. I was just thinking of that. But calming music. I really do. I really think the calming music is so helpful to them. And we can't really do massage right now. And a lot of facilities still are doing a lot of massage. And I just think we probably should stop that at least. What do you think about that, Dr. Calvet? Some facilities.
Yeah, I think what you said about limiting other contractors or whatever is extremely important, extremely important. And the thing you said about hospice, now one of our outbreaks was probably related to an infected hospice worker. You need to give people the essential things that they need to do, but the fewer of those people, only for the most critical services, really. And if you can find ways that you're talking about to kind of replace some of those services, that's the best. Limit your staff. And I think one of the slides said, if you have a combined assisted living memory care, try to have your staff only in memory care, only work there and not work other areas.
Now, while they're passing away, we are allowing, the state is allowing us to allow from their guideline for the family to come in the room. So what I've kind of done, and I'm sure we all have fire exits, maybe have them come through the side of the house, through the fire exit. And don't forget, if someone passes, when the morgue comes, have them go out. Don't let them go through the house. I know some people still allow them to go through the house. And when the pharmacy comes to deliver, really just encourage them not to come in. They're still bolted in. Just say, I'm so sorry, leave the meds we'll come right away outside. You know, there's just a lot of people forgetting the boundaries. And that's been quite a big problem. The fogging machine, I wanted to let you know, is more affordable. It's a fogging disinfectant machine. I try not to go out and use these companies. I know they're all over right now, but they're $600 to $1,000 a home. Wow. And that really add up, where you can get a fogging machine with the disinfectant and have your maintenance person or someone with a lot of great protective equipment on spray. And I know we don't have any cases, but still we want to be really careful when you're spraying. And don't let the residents stay inside while you're spraying, because it has a really strong odor and they will really complain. And I think if they could have a little picnic outside, you know, spread out, that would be the best.
Yeah, I would just say before you maybe invest in one of those things, I would pose that question to our infection prevention specialist next week, because that is a significant outlay of resources. Maybe best to buy a few iPads or something for that money, but let's let them address that. I think certainly cleaning the high touch surface is very, very important. And I like that the fact that you mentioned going outside. A lot of people, I don't know, the stay-at-home order, I think people misinterpreted like, oh, if I get outside, I'm going to get it. It's floating around in the air. It's really hard, I think, to get this outside, especially if you're socially distanced. So, if you're in a small RCFE and you have a little backyard, let your people go out backyard. They need the vitamin D, they need the fresh air, they need the exercise, but try to keep them 6 feet apart. And if you want to, there's some places that we've said, well, can we have visitors come and visit with them outside as long as they're 6 feet apart? I think that's probably not unreasonable, but I wouldn't let it go. You really have to enforce that 6 feet or more and limit the time amount. But I'm a definite proponent of having people come in for end of life. I've just seen too many people in the skilled nursing facilities dying alone. And it's just the saddest thing if you have to pass without your loved ones there with you. I've been able to go in and actually pray with a couple people while they're on their last legs because their family can't come in.
What about using spiritual care and prayer, Dr. DuPont? Have you had some experience with that lately, in especially as people are becoming more ill? Maybe you haven't had COVID in your homes, but you still have people that are at end of life. What kinds of techniques have you used?
The pastor, the priest, doing the blessing of the sick. We've been doing it FaceTime. It's
on FaceTime, okay.
FaceTime.
That's great.
It's been working out really well. Our chaplain isn't visiting anymore, but he'll call up. We'll put him on speaker, and they can all hear him too. And he'll maybe do a Bible reading, or we had a rabbi call in too. So it's been working out pretty well.
Lots of creative ways. Great. We're getting close to the end of our time. Is there another question or another comment from one of the participants?
Patty,
yes.
This is Shelley Woolery.
Hi, from the Ombudsman's Office, from Council on
Right.
Aging.
So I thought I'd stick my 2 cents in, of course. I just want, number one, there's over 900 residential facilities.
Okay.
So, that makes it even more, difficult. I understand that. I just want everyone to know we're still here. So please encourage family members and residents and facilities to call us. We're here to help. We're not obviously coming into facilities, but we are calling all of our facilities regularly. So we're contacting nursing homes like once a week. We're contacting the larger assisted living, a couple of times a month at least. And the small 6 beds, we don't want them to think we're harassing them. So we call them about once a month or more if it seems appropriate, just to check in with them to see if they need anything, if they need any resources. So I just want you to know that, we have not abandoned our residents in any way. I have to say for the memory care patients in some of the facilities we've talked to, they're having huge issues with behavior problems because they don't have that person that has always been there before, their family member or whoever it was, to kind of keep that resident on track in terms of continuity and knowing that they could count on that person. And there's just not enough staff in most facilities to fill in that gap. So unfortunately, we've had many facilities that have decided to use medication to keep the residents more calm. And that's been a concern for all of us. So I just, again, overall, I think everyone's working as hard as they can, the facilities and the staff, to do their very best to accommodate and provide. I would like to, Dr. DuPont, I would love if we could just clone you so that you could send all of your ideas out, so that any way you can to send some of these ideas to other providers would be incredible. One of the things we're seeing is that residents are getting very depressed, very anxious, because literally they feel like they're a prisoner in their room. It's just heartbreaking. It's just
How about this? How about when we put together the information from Dr. DuPont and Dr. Calvet, perhaps that would be something you could send out to all of the RCFEs that you have listed, because I think many of us find that some of the information that we get from Sacramento is not always very accurate, and you probably have the most up-to-date list.
We can't understand it most of the time. So, But yes, and we've been trying to get emails for all the facilities so that we can do that. We have an activity book that we're going to be sending very soon. But it's, you know, obviously getting emails for almost 1,000 facilities is pretty daunting. So even with calling them, but we've been working on that, and each individual ombudsman is hoping to be able to do that. So yes, we will do our best to give them the resources for
Great.
sure.
Best poster ever. So I don't know if all of us have seen it, but I have it at all my homes, and it's the new ombudsman poster saying, we're here, call us if you have any concerns, because, you know,
Thank you.
families are so upset over not visiting. So 3 or 4 I have referred to the ombudsman.
Thank you. We appreciate that.
They need that calming reassurance. And the ombudsman's the perfect person for that. The state isn't. They're really busy. Our evaluators are working overtime, and I'm sure the ombudsman are too. However, they have that listening ear where they can redirect the person.
Yeah.
And we just had someone ask, how can they get the ombudsman poster?
Well, we sent those to every facility. So most facilities should have that new poster, and that was not really put out by the state. That was our program in Orange and our program in Riverside. Okay. So that was, you know, and the programs all over the state are making the same type of effort, you know, to try to make that connection with the facilities and let them know, and let the families know we're still here.
Will they be able to get an additional poster if they either didn't get one or
Absolutely.
need one?
Just have them call the same number they've always called for the ombudsman program, and or call their ombudsman, and yes, we'll get it to them. Okay,
very well.
Patty, give you a copy of one, and then you can link it to the back page of our.
Wonderful. Great. All right, we are at 11 o'clock. It looks like we have one last question. Couple of folks have said they don't have posters yet, so we'll do everything we can to get you posters. Thank you. I really want to thank Dr. DuPont and Dr. Calvet for all the effort and all the expertise and really all the energy and talent that you bring to this effort to not only protect the older adults that we all serve, but that you're so willing to generously share your knowledge and expertise. So here's a little round of applause from all of us. Thank you very much. And to all of you on the program now, we'll meet again on the 24th, the same time at 9:30. Jessica will send you out a fresh Zoom link, and we will continue the discussion and bring back any new learnings that we've had as we've tried to do some of these great new practical applications. Thank you very much. Have a safe day, and wear your masks in public, please. Take care.
Thank you.
Thanks, Patty.
Bye-bye.
Okay. All right, well, let's go do my thing.